spectrum. The tetracyclines are the broad spectrum antibiotic, okay? Tetracycline is the most known one. The other one that you're going to see, especially in dentistry, would be minocycline, which is available actually either orally or locally injected. So I just wanted you to know that that I have tetracycline in the family. My granddog, Bruiser, doxycycline. That's actually not Bruiser, but I just love that, and I forgot to put it in last year. So that looks a lot like my granddog, Bruisey. He's a pretty good guy, so there he is. But do you get it? It's a doxycycline. Okay, well, that took a while. Okay. Figured you needed a little, like, help here. Okay. Tetracyclines have very extensive medical and dental use. It's rarely the drug of choice for a specific infection, right? Because it's a very broad spectrum antibiotic. It's also used to treat things that are a little bit more broad, like acne, sometimes pulmonary infections, people with COPD that have a pulmonary infection. It's also used for traveler's diarrhea, which I think is strange because it also causes diarrhea for some people. Dentally, it can be used for certain periodontal conditions because even taken orally, believe it or not, it's actually very high concentrations in the pocket, okay, in the gingival clavicular fluid, if you will. So that's used there. But in a lot of cases, now that we have the locally delivered stuff, talk about having a high concentration in the gingival clavicular fluid when you inject it in there. Yes, we absolutely get that. And one of the things I show here is Arrestin. It is little microspheres. There's kind of a powder form that you have in a little syringe-like thing that's actually injected into a pocket, right into there, and it then kind of gels up and stays in there for several days and kills off the bacteria for a localized infection. So it's kind of cool. It's absorbed fairly rapidly, but it does cross over into the saliva, and it goes into the milk of lactating mothers, and it would be stored in the dentin and enamel of unerupted teeth and concentrated in the gingival and clavicular fluid. So it is something that crosses the placenta, it enters fetal circulation, and because of the effect that it has on bones and teeth, we do not use it in nursing mothers or in young children. It is bacteriostatic, okay? It is broad spectrum. There is resistance to it, but it happens over a longer period of time. Resistance is becoming more common, but it hasn't been as much of a problem as like with the penicillins. Penicillin is still the choice for a dental infection, okay, that is not related to periodontal disease. All right, and then we may go with something like a tetracycline. And you're going to see some confusion where you think, I thought you don't use that for that, but now we're using it. With specific types of infections that occur in a specific way, we use the drug that works. And hopefully the dentist has a handle on what has worked for him and or her in the past. GI effects, it can cause stomach upset, nausea, vomiting, diarrhea. Superinfection with Candida can happen, okay? Candida infections are a superinfection that can happen with a lot of the antibiotics. Because a broad spectrum kills a lot, it's going to happen more readily. Hepatotoxicity can happen, particularly with IV use, and again, over a long period of time. Teeth and bones, again, I show the pregnant mother there because it should not be used for a pregnant woman or young children, okay, that still have developing teeth. It can interfere with the formation of teeth and bones, and also can cause incredible staining. All right, someone like this would have, could not be treated with bleaching, would probably aesthetically have to have like veneers or something put on. So it can be quite disfiguring. Again, the superinfection with Candida is the more likely to happen with someone who is immunocompromised. Okay, oral candidiasis, denture stomatitis, vaginal or yeast infections. We do know that if you've ever been given a tetracycline, the doctor will tell you be careful going out in the sun, become photosensitive. Minocycline in particular can cause a central nervous system effects, dizziness, vertigo. It can cause liver toxicity, kidney toxicity, and anaphylactic reactions are not terribly common, but they can happen. And a lot of these aren't as big a problem, especially with the allergy, as some of the other drugs. So, what killed the doughboy? I'm trying. I knew by this point you guys were like, all these drugs, okay? It's not too bad. But at least this group of drugs is very relatable to what we do, right? So I think that makes it a little bit more interesting. And you're going to run into this stuff all the time. You really need to know it. There are some drug interactions or food interactions with cations, and cations are calcium-containing foods, antacids, minerals that people might be taking. It's going to minimize the proper absorption of the tetracyclines, so we have to be careful with that. It can potentiate the effects of the oral sulfonylureas, which are diabetes medications, so that would make them work more and then cause your blood sugar to plunge. So careful with people taking, you know, things like metformin that we'll talk about. Digoxin is a drug for the heart. Lithium, which is given for people with bipolar disorder. Theophylline, which is asthma, COPD. It can react with those drugs. Barbiturates and phenytoin, which are used for a variety of reasons, including seizure disorders, can reduce the doxycycline effects. Oral contraceptives, it would reduce their effectiveness, and it would increase the action of some of the oral anticoagulants, like we talked about, like with warfarin. Okay. And what was the one that you asked about, Deshanti? Clindamycin before? So we're talking about that. Clindamycin is bacteriostatic. Gram-positive organisms and some anaerobic organisms like the Bacteroides species. It is used most often for these anaerobic organisms when the patient is allergic to penicillin. It may be used for staph infections. Clindamycin is going to be your alternative choice if someone's allergic to penicillin for a pre-medication before an oral procedure. Okay, so prophylactic dental pre-medication with clindamycin is fairly common for those people that are allergic to penicillin. That's an important one to remember. There you go. It can be given orally, IV, IM, topically, vaginally. It's well absorbed. Food doesn't interfere with it, which is good. It's distributed through the body and excreted in the normal manner in the urine and feces, so nothing terrible there. Now here's where we can get to problems with it, okay? Pseudomembranous colitis, diarrhea, nauseating, vomiting, enterocolitis, inflammation there, and abdominal cramps. So if we give this drug, we have to warn people about this. What happens is we get a super infection caused by C. difficile, okay? C. diff infection, if you will, bacteria. And we get severe, persistent, bloody stools and blood and mucus. And this would be, this again could be something that could be potentially fatal, but people are very, very sick. So we must inform people that we give this drug to that this might happen, to immediately stop taking it and seek care. It can actually even occur weeks after use because of the suppression of the flora in the GI tract. So definitely something to look out for. Because again, it's broad spectrum, Candida albicans can happen with clindamycin, and allergy, you would see a skin rash that's called mobiliform, so it's really kind of a measly kind of looking rash that happens, so warn people about that. Metronidazole, okay, or Flagyl is one of the brand names, and it has trichomonal, amoebicidal, and bactericidal action, and that's actually I think it's a trichomonas infection. It's kind of gross looking, but it was kind of interesting. It is useful in dentistry because it has really good anaerobic action, okay, efficacy. If we find out that we have an anaerobic infection. For people that have persistent, very active periodontal disease that we have just cannot get a hold on no matter what we do locally, and we've tried other antibiotics, they may be put on metronidazole. So it's very, very good. It does also concentrate really well in the gingival clavicular fluid, and it's been shown to have anti-inflammatory effects, so that can be a plus as well. Medically, believe it or not, it's actually used to treat that C. diff infection, the Clostridium difficile infection for pseudomembranous colitis, so we actually throw something else at it. In dentistry, it's useful for the periodontal infections as I just prescribed. When you've identified that anaerobes are the problem, it also can be combined with amoxicillin to have a double effect for those infections. So you have that patient that you've cultured, you've identified the anaerobes, you've thrown everything in the book at them periodontally, and they're still having breakdown of tissue and still not getting their infection under control. They may do a combination of metronidazole and amoxicillin. Those are big guns. and it's really people that know what they're doing in giving these to patients. Nausea, anorexia, diarrhea, and vomiting. This is starting to sound like a broken record, but it happens with a lot of the bacteria because of the effect on all of the normal flora that we have there. CNS effect does happen with this, as I mentioned before. Headaches, dizziness, it can have that. Definitely, I remember, being in an office where we prescribe these to patients, 0 alcohol, even alcohol mouthwash, zippity-doo-dah, okay? They can get really, really, really sick. So we tell people no alcohol whatsoever in using metronidazole. Renal toxicity can happen, dry mouth can happen, unpleasant metallic taste in the mouth. So warning people about this so they don't think they're dying or something terrible is going on. Black-furred tongue, which may be a fungal overgrowth. And giving it, because of the toxicity during pregnancy and nursing, is completely contraindicated. It can also potentiate warfarin. When we talk about potentiate, does that mean it makes something work more or less? More. Potentiates its effect, so more anticoagulant effect. So let's just discuss here, again, go over this rational use, the proper use of anti-infectives in dentistry in looking at the different stages of infection, and now that you understand about it, and treating it in a rational manner. In the early phase, we've got those gram-positive organisms. Mixed phase, anaerobes and aerobes. Stage 3, exclusively anaerobes. Let's use the right antibiotic, okay? But we also know that drainage can be established, we don't need an antibiotic, okay? I can probably not say that enough, okay? In people that have a normal immunocompetent, not immunocompromised effect. Okay, so stage 1, something like an acute abscess, gram-positive aerobic bacteria, drug of choice is penicillin V or amoxicillin for patients that aren't allergic to it, 500 milligrams every 6 hours for 5 to 7 days. You should know this routine, okay? Erythromycin or clindamycin for people that are allergic to penicillin. Stage 1, that's what they should be treated with, and yes, you do need to know this. Stage 2, if the infection is mixed, okay, we're still going to go with something like, again, we have the gram-positive, we're going to look at something like our penicillins. If we have the anaerobic gram, that's further along in the spectrum of bacteria that are growing there, the two best would be the clindamycin and the metronidazole, and penicillin V could also be used, and sometimes a mixture of those things. So a mixed infection, these would be the drugs of choice. There is some crossover. When we get to that stage 3 anaerobic, incision and drainage is most often still the thing to do, okay, to release the bacteria, clear up the infection. But if we have a chronic infection that is persistent, anaerobic coverage with clindamycin and metronidazole would be used. So do you see that there's almost like the penicillin crosses over into the mixed, and then we get to the clindamycin, then we get to the anaerobic, and now we've got, yes, you can still use clindamycin, but we might have to go to the metronidazole, okay, or any mixture of those things. So you should know those 3 things. When we prescribe an antibiotic and it has not been effective, there's usually a few reasons for this, okay, that we can identify. So this is where we need to step up our game a little bit. Patient compliance, okay? They didn't fill the prescription. They didn't finish taking it, okay? We used an ineffective antibiotic. We didn't use the right antibiotic at the right stage of the infection. We didn't debride well enough. We left tissue there that's still developing an infection around it, okay? There's still exudate. It wasn't drained properly, okay? It wasn't drained properly. We have an organism that's resistant. The concentration didn't reach the site of the infection. Maybe it's too anaerobic at this point, we don't know. Or we have inadequate host defenses. Even people that are relatively healthy can become immunocompromised by a variety of different things. So in all of this, using the proper drug for the proper amount of time, educating ourselves and educating our patient are all involved. It's really a multi-stage thing, but that could be some of the reason. There are some drugs that are mentioned here that are for non-dental use because our patients are only taking drugs for that. I'm only mentioning a couple of them. I'm not using all the ones that were in your book because I don't think they're related enough to what we do. The information is there for you, but I tried to whittle it down just a little bit. One of them is vancomycin, and I do mention this one because it is only reserved for those infections, okay, which are not capable of being treated, systemic infections by they have not been effective against them. So this would be something like MRSA, methicillin-resistant infections, okay? And then you hear about people getting this. It's usually administered only intravenously, so it's not something that we're going to be using, but your patient may have used it. When it's used orally, it's because of organisms in the GI tract, and it's called gorillacillin because it has lots of adverse reactions, risk-benefit ratio here. It is bactericidal. It has a negative, it has a narrow spectrum of activity. And it is often a last resort when you have staph infections that have been resistant to other things, like again methicillin-resistant Staphylococcus aureus infection. Okay, they may use this then. They have now discovered bacteria that are becoming resistant to vancomycin. So the list just goes on and on and on. Adverse reactions that can happen: GI, nausea, and vomiting. This one is very particular to it. Actually, the reason I include this is I had a student tell me a couple of years ago that it was on the boards. So like, which drug causes red man syndrome, which is this generalized rash that makes you look red. And it was vancomycin. So just so you know. Hypotension, so a sudden drop in blood pressure can happen. Kidney damage, major with this, so you only use it again as a last resort. And it has been known to cause permanent deafness. I don't know why, it's not known why, but again, this is the big guns, okay, when nothing else has worked. You guys have also probably heard of some of the quinolones, particularly Cipro. Ciprofloxacin is the one to know. It's bactericidal, and it's the first orally active agent that could counteract the Pseudomonas species, which are resistant to penicillins. There are some dental infections that have been indicated with Pseudomonas. I don't see this used for that, but the reason we saw this is there was a bioterrorism agent called anthrax, which was out of some years ago. Do you remember hearing about people being nailed through bioterrorism? That was anthrax. You guys most of you are too young for that. Okay, so people were worried about opening up their mail because of anthrax infection, right? Okay, but people were actually hogging Cipro and having it available in case of anthrax bioterrorism. They had it like available in all the government buildings. It was absolutely crazy. When I mentioned the Pseudomonas, there has been some indication. I've read this before, but I haven't seen it actually happen. That because of P. gingivalis, which is one of the bacteria that is involved in periodontal disease, that it may be indicated for that in the future. But haven't seen a whole lot about that. Your book does mention it though. GI effects, as usual,